Thank you all very much for joining us for another episode of Scientifically Speaking in conjunction with Modern Aesthetic and Practical Dermatology magazine. I'm really excited today to have Dr. Mara Weinstein from Rochester, New York, Dr. Doris Day from New York City, and Dr. Anna Guanche from Los Angeles, California. Thank you all very much for being a part of this session on microneedling. So Anna, tell us about you and your hat and your practice in Los Angeles.
I'm in practice in Calabasas and Beverly Hills, so LA area. My hat is from Boston College and also my sweatshirt because my daughter is in her third year in college there and she is pre-med and she wants to be a dermatologist unless my husband, who's an orthopedic surgeon, tries to convince her to become an orthopedic surgeon, which I'm not going to let that happen.
Fantastic. And Doris Day, I know you have a story about your children as well.
Yes, well, I'm a dermatologist in New York City, and I'm wearing this because my son went to Johns Hopkins for undergrad and just finished his master's there as well. And my daughter is also in med school, but not at Johns Hopkins. And she is doing a research here at Sinai, and she is going to be a dermatologist. So I went out, she's following in my footsteps, and that's very exciting.
That's awesome. And then Mara?
So exciting.
Yeah, so I'm here in upstate New York in Rochester. I teach at the university. I developed the cosmetics and laser program here at the U of R. And my hat is significant because it's my alma mater. So I went to Princeton, so we were Tigers through and through. I was also on the women's lightweight crew team, and we won the national championship the year that I rode. And then this hat, lastly, was my dad's. So I found it in a box and I inherited it, and he wore it to our winning race.
Wow, that crew team. I had no idea. That's fantastic. So microneedling is a part of all of our practices in aesthetics. We're all board certified dermatologists, and there's many people who do microneedling. We know that there's different technologies, from rolling devices to stamping devices to more modern day FDA cleared pens, such as Crown Aesthetics Skin Pen and then Evo Pen from Eclipse. So tell us how you guys introduce sort of microneedling into your practice. How do you position it to patients? And really, what do you think the best uses of these technologies are? I'm going to have you start, Doris.
Yeah, I think that the technology is very exciting. It started with a lot of home rollers, which I actually don't approve of. But I find that the place I have the most use for it is for acne scarring and for rhytids, especially around the mouth. And it's really, I think of it as a delivery mechanism of delivering growth factors and topicals to the skin, more than just a device that's going to create an end result by itself. And I like that it's not heat-based. So for my patients who are prone to hyperpigmentation, I find that it's very useful. And we're creative in how we use it. So we're creative in what growth factors we use along with it. Sometimes there are things that we would normally inject, like Sculptra. Other times it's specific growth factors we get. So I find it to be a great additive. And if you're just starting your practice, they're not very expensive. And it's a great way to introduce aesthetics into your office without a great overhead.
So Anna, I'm sure your practice is very much LA, where patients come in and they don't want downtime, and Doris's patients in New York City probably say the same thing. Whereas in real world America, in Denver or in upstate New York, I think people are okay with downtime a lot of times because they don't have major things going on TV or in Hollywood screens. But nevertheless, you have to really figure out what suits a patient best and what technology works well for them. So Anna, talk to us how you position microneedling for your patients.
100%, Dr. Cohen. It is a big challenge in Calabasas, especially to have any downtime. People are pretty spoiled, but we do introduce microneedling in segments sometimes if there's acne scarring in a certain portion of the face. I find that microneedling is a lot more visible, the post-procedure around the eyes where the skin is thinner. That takes a longer time to recover, but on the lower cheeks where a lot of people have trouble either with lines or they have acne scarrings in this area, they might opt to treat that area. And alternatively, we can do shallow microneedling and do a smear. So we'll either do platelet-rich plasma, and that augments the result, increases the collagen production, or sometimes we do a tranexamic acid smear for people with melasma. So different things we do to combine with shallow instead of deep. However, if they do have acne scarring, I feel they do need to have deep microneedling to see a result. And as you're saying, there's so many different devices. So we have the Fraxel, we have radio frequency microneedling, and we have the stamping technique that you were talking about for superficial, perfection of the skin. So we do have to kind of wedge it in there depending on specifically what's going on with the patient.
When it comes to microneedling, I think this can apply to various types of skin types. So really, how do you position this in your practice? Is it a maintenance treatment? Are you using it as a primary treatment for acne scars or scars in general, or really as a way to have enhanced delivery of some of the topicals that we mentioned?
Yeah, so microneedling has a special place in my practice because I see a lot of skin of color patients. And downtime isn't so much of an issue, as you mentioned here in Rochester. So I have a ton of lasers, and I really sort of dictate who gets what treatment based on 3 factors. So the first is cost. So, there's always going to be a cost question, and microneedling comes at a lower cost to the practice and to the patient. Although I do counsel that they're going to need, as many treatments. So over time, it might add up. But some people prefer to pay it in increments and they'll kind of wait for their results. So the cost is definitely an issue. The second is skin type. So in my darker skin patients, I talk to them about microneedling a lot. And we're looking at things like scars, acne scarring, facial traumatic scars. We've done a bit of striae as well, so sort of off the body, and that it works wonderfully for all of those conditions in my darker skin patients. And then the third thing is downtime. And so, like I said, downtime isn't as much of an issue, but if somebody absolutely doesn't want downtime, doesn't want swelling, then I'll turn to microneedling. And then you asked about, how we use it. I often use it as a single modality, although recently I've started combining it in my melasma patients. So we've done microneedling followed by a sal acid peel. And we've seen some really nice results there.
Doris, I know you've had some success with treating acne scars with traditional microneedling. If you can walk us through a case where you thought it was very helpful and beneficial for your patient.
Yeah, so I had this young woman, and in 20 years of practice, what I've observed is that acne scars that look mild in your 20s can look deep in your 40s or 50s as your hormones change and as we lose collagen and the ability to repair our skin, and wrinkles sort of set in. So I've been a lot more aggressive about treating my younger patients with even what seemed like mild acne scarring. So in this case, we did 3 sessions of microneedling, just traditional microneedling at a 1.5 millimeter depth at 6-week intervals. And we used topical growth factors. I use one called Calicim that's from an isolated deer population in New Zealand. It's stem cell derived growth factors. And we would put that and the topical hyperdilute sculptor right on top. And then when she went home, we used other growth factors as well. And we found that she had really nice results just after 3 sessions. So I typically do 3 sessions at 4 to 6 week intervals. And then I wait 3 to 6 months so the skin sort of unremembers that wounding process. Because I think that stimulation of wounding, your skin can adapt to it, which can lead to decreased efficacy. I don't know for a fact, but that's just my feeling. So I just do 3 sessions, then I wait 6 months, and then I do another one. So you can see in the next slide, a closer up. In the next 2 slides, you can kind of see the other side. And then the last slide is a closer up view of the improvement of acne scarring. The deepest scars are not quite gone, but with more sessions, I think that will continue to improve, and along with retinoid.
So Doris, are you doing combination therapy? This is a really nice result. I would look at this and say, it might be nice to consider doing a little subcision there or a little cross technique in some of the areas that look more boxcar. What have you done in terms of combination therapy?
Absolutely. It always depends on the acne scarring, but I think everything we do is combination therapy. This will get you to a point. I've done threads. I have some beautiful before and afters of combining this with threads that go along the cheek underneath the scars. If they're ice pick scars, I do TCA cross and sometimes even just some Sculptra in the area underneath the skin to improve the skin quality. So, or combining it with even a CO2 laser, although I use less of the lasers and more of the other techniques, whether it's subcision, threads, or TCA to help improve what's left of the scars.
So Anna, I know you've had success treating acne scars, and I think it's really one of the great uses for microneedling or radio frequency bipolar microneedling. So walk us through one of your cases for traditional acne scars.
So yes, I definitely use radio frequency microneedling and traditional deep microneedling for acne scars. The option for this patient did have to do with budget. So I find, as Mara was saying, that it's the cost that sometimes dictates which procedure we choose. And I will admit that each patient has a different response depending on, you know, their skin type and how they heal. But this young man got an amazing result. This is only after one treatment. And so he got one deep microneedling at 2.5 millimeter depth, and his result was phenomenal. And then he did subsequent treatments as well. We have a video of his subsequent treatment, but all his friends and family and everybody noticed that there was a dramatic change with only one treatment. And to your comment earlier about combination, if we did do a series and he didn't really get rid of the deeper scars on the cheek, we would definitely either do subcision or my go-to, which is filler. And I find when I do filler in the deepest scars, over time, the collagen continues to remodel and you don't have to continue to do the filler procedure. So we always do combination treatments for patients.
So in this particular patient, I think this is really significant results for one treatment session. Honestly, can you tell us how many passes you did, what depth you were at, maybe what device you were using, and if you contemplated doing a combination of some of the things Doris mentioned in terms of adding something on top of the microneedling hole, such as a topical formulation or PRP or Sculptra?
Honestly, we used the original Eclipse pen before we got the recent Evo upgrade, which is FDA cleared. And we went 2 to 2.5 millimeters. Some areas I do more shallow, like the forehead, where it bleeds more easily because you have the bony sort of backdrop. And we just used a hyaluronic acid glide to help it glide. We do a vertical pass, horizontal pass, and then a circular pass. I just basically do a circular pass on the acne scarring area. So the one thing I don't like to put a lot of different topical compounds on the skin other than hyaluronic acid, but sometimes there will be a little residual anesthetic on the skin. And in that case, it might look a little milky and people will message me all the time asking me what that is. But this is our young man. He's actually, I think, an aspiring actor, and he really was amazed at the results himself. So here I am, I'm doing the vertical and horizontal as I was talking about, and then I'll do a circular pass. So I don't know if she got all that in there in the video, but I always make sure that we get to the point of pinpoint bleeding because we want to have that almost platelet-rich plasma-like effect, even if we don't use platelet-rich plasma, because I really do believe the growth factors are, you know, when the platelet adheres to the micro injury in the skin. So he basically will have very little downtime. He has about 2 or 3 days of redness. And the procedure, as I explained to my patients, is not as painful as it looks like it is. It's most tender on the forehead. So I think on his second treatment, he opted to skip his forehead, as you see, but it definitely gives beautiful results and about 2 or 3 days of sort of flushing. And sometimes almost, I say, like an abraded look, like there's scratches on your skin, and then it settles down.
So I think we've seen some really nice results with acne scars. Maura, if you can talk to us about other types of scars. I think a lot of times when we think of microneedling or RF microneedling, our first thought is acne scars, but in reality, I think you can use this for surgical scars. I've seen Tina Alster present some really nice data about shave biopsy scars as well, in her experience that many of the patients in her practice are actually treated on that shave biopsy area of the face with pretty significant focal microneedling. So walk us through this case here.
Yeah, absolutely. And just to your point, Jill, I think that it's so useful for those isolated surgical scars. I work alongside a lot of Mohs surgeons and see their patients post-operatively, and have done a ton of microneedling cases, especially on the nose, and have seen really nice results from that. But in this patient, this is one of my favorite examples, because not only is it a darker skin type patient, but you can really see the changes that the skin can go through, and you don't need to freak out essentially, because you can see here at baseline, she has a little bit of hypopigmentation within the scar. This is a traumatic scar from a car accident. And then 8 weeks post the first treatment, she came in and was very hyperpigmented. And at that time, we were worried and sort of wondering if we should proceed. But in fact, we did, and we didn't use any topical lightening agents or anything. I just continued with treatment. And you can see 12 weeks post her second treatment, most of that hyperpigmentation has faded. And then 1 year later, so she had 6 treatments total, spaced anywhere between 4 to 8 weeks apart. And that was just due to her schedule and mine, no particular reasoning behind that. She was really happy with this result at the end. And unfortunately, you can't really see the end result of this preauricular scar, but it was essentially gone. And so in this patient, I think there are a few things that we can take home. One, if you see hyperpigmentation, to sort of counsel the patient through. We know that microneedling is a device that doesn't have heat, making it safer in darker skin. It doesn't have that immediate effect of erythema on the skin. And then also just being patient and sort of coaching the patient through these results, can really yield some nice outcomes.
So Mara, when you take a look at a patient who has hyperpigmentation and you go through your thought process of what you can use in addition to the device that we're talking about, or a laser, what goes through your head in terms of the topicals? Do you pre-start the topicals like a hydroquinone? Do you use it for a short period of time? Are you giving the patient topical steroid right at the time of the treatment, or are you having them put on a regimen that includes sun protection afterwards?
Yeah, so I would say all of the above, but to break it down, usually if I'm doing a laser procedure, I will have them pre-treat with hydroquinone, either 4%, or recently we've been using the combination from Skin Medicinals, which is an 8% hydroquinone. I'll have them pre-treat for at least 2 weeks, then do the laser procedure. Post-procedure, I will prescribe Lidex, and I'll have them use the ointment twice a day for 3 days. And then once they're healed, they'll resume their normal skincare routine. But I do post-treat pretty regularly with topical steroids and pre-treat with lightening agents, especially if I'm doing a laser.
So one really helpful tip I got from the literature and watching a lecture was Hector Leal Silva, who really published some very good data about looking at some of the palmar creases that people have, and people who have a tendency to really significant hyperpigmentation will actually have hyperpigmentation in their palmar creases. So that may actually be a sign for me when I meet with them ahead of time to get them on some sort of pre-regimen, including a temporary hydroquinone, including steroids immediately after, and then thinking about the things that we can use outside of hydroquinone afterwards, such as tranexamic acid or many of the things that we use. But I do want to mention that sometimes when people are applying something directly at the time of the treatment, where you're actually enhancing the delivery through these little microchannels, there are some concerns about the products themselves getting below the surface of the skin and inducing a granuloma. So I want to go to Doris to talk to her about her experience taking care of a patient who had just that.
One of my other observations about acne scars is that where you see the depression isn't necessarily the scar itself. When I was doing threads underneath the skin, or when you do subcision, a lot of times, if you pay attention, the bound down collagen is in the vicinity, but not directly under the scar. And that bound down collagen around that area can create that puckering effect that pulls down where you see the depression of the acne scar, depending on the type of scarring you have. So when I do microneedling or any other treatment for acne scar, I'm never just treating the scar alone, I'm treating the entire area. And I think that's really important to understand, that when you treat the scars, focus on the whole area, not just where you see the scar itself. In this case, this was a patient who had had microneedling done at a med spa, and they applied a vitamin C that I think they had just gotten online. So it wasn't a vitamin C that had been tested along with microneedling. And after the treatment, she had erythema, she had these bumps, and this is 6 months post-treatment. So they were persistent. And then if you look at the next slide, we have some closer up images. It almost looks like she was wearing a baseball cap that left an indentation, and that is a permanent, or well, semi-permanent indentation. So we did a biopsy, or biopsy was done. I didn't do the biopsy, but she had a biopsy of the site. And that's the last slide that shows, so that's a close-up view of how indurated and granulomatous they looked. So on histology, basically there was no bacteria or fungi, no foreign material identified, just dermal inflammatory infiltrate, basically. So it was kind of non-specific. Eventually, they were treated with just low-dose intralesional steroids, and they resolved over time, but it took almost a year to get them to resolve. So I'm very careful about what I use at the time, because you are creating these microchannels depending on how deep you go, and that's a pathway into the skin, and you can create problems as much as you're trying to solve them.
So it's an interesting point, because I think a lot of times people are cavalier about what they put on a treatment area after the treatment. And when it's some type of fractional or microneedling device, we have to really think about the original intention of that product. If it was intended as a cream to sit on the surface of the skin and not have that much penetration, that's very different than something that really the intention was to inject it. So we have intralesional steroid formulations, we have intralesional 5-FU formulations, and then obviously things like Sculptra that are intended to go deep. But when it comes to these topicals, we really have to look to products that are specifically formulated to be applied with the procedure. So there's several companies that have developed products in conjunction with either their device or their laser that is intended to be enhanced with these types of technologies. But as it goes back to, you can always go back to platelet-rich plasma. And in my experience, that seems to be something where if somebody's worried about the downtime in terms of erythema or swelling, or they understand that this PRP can potentially be synergistic with their not only healing process, but with their eventual result, I am not apprehensive about incorporating PRP into any of these technologies. And I think it can be very exciting. Some of the data is showing, not just with microneedling, but also with certain lasers, that you can actually have enhanced improvement and you can have enhanced recovery with platelet-rich plasma. This is a paper I wrote a number of years ago with a few other people from Mount Sinai, but it just shows an acne scar patient on the temple that was treated with microneedling and incorporating PRP. So I think when you go to town over an area, you can certainly be much more aggressive on the individual scars. And then in order to try to expedite the recovery process, using PRP, so platelet-rich plasma from their own blood draw, and really trying to deliver this focally and enhance the results, I think really makes a lot of sense. And we don't see the concern about applying that versus some of the things where Doris showed. And vitamin C, at least in my experience, has been a culprit a few times. And it's interesting, when you're taking care of some of these patients, one of the treatments actually may be to use the same device that you started with. You know, with traditional microneedling, whether it's a stamping or rolling or one of the pen devices, I think we can see improvement in acne scars. In my opinion, the area where bipolar fractional radiofrequency, or what some people call radiofrequency microneedling, really shines is for acne scars. I think being able to deliver those holes into the skin with the microneedling type of device, and then having the energy delivered with the positive and negative polarity, stimulating coagulation and that conduction and heat, can be very, very helpful. And this is a treatment in our office that we use even for darker skin types. This is a patient who had pretty significant acne scars. You can see after 3 sessions, he has had a very nice improvement. We did not combine this with any other topical treatments or technologies at the same time, such as PRP. This is straight microneedling RF. And I think that this is really nice standardized photos and positioning showing that he's had some improvement. You know, most of the time when we incorporate this, we see patients actually do better in terms of their acne scars, as well as some of the active acneiform lesions, which you can see here as well. And he did certainly continue on some of his acne treatments. So that may actually be an enhanced delivery type of process. If we look at the next slide, this comes from a project that I did a few years ago with Omar Ibrahimi and Bob Weiss and some other docs, including Vic Ross and Flor Mayoral, really with this type of patient who has acne scars, seeing nice improvement over the course of similarly 3 treatment sessions. And these technologies can be very helpful. So in our practice, we have Genius and we have Morpheus 8. And these are really nice technologies. There's not a lot of discomfort when you compare it to some of the other treatments, such as heavy laser resurfacing, and people do very well with usually 2 or 3 days of some swelling, some erythema, and perhaps a bit of patterning. So Doris, I know you've had really some good success with treating acne scars with radiofrequency microneedling. So let's take a look at some of your pictures.
This is a young man who had pretty significant acne scars, really bothered by them, and it was affecting his self-esteem. So we used the RF with microneedling along the temples, the forehead, cheeks, along the chin, the sides of the chin where he had the significant acne scars. And again, I treat the whole area, not just right over the scars. And he had really beautiful improvement. And what's so nice when you see young people, especially who are so affected at such an important time of their life, he was just getting ready to start college. And to see his confidence level go up was really very encouraging. He was just so much happier. And it worked really well. I have the EndyMed Intensive, which is a gold-plated, non-insulated microneedle RF device. And I find that each one has its own advantages and disadvantages, but you have to know how to use the energy of the device that you have in order to get the most out of it.
In terms of these bipolar fractional radiofrequency devices, I think, you know, similar to traditional microneedling, I think we see the best results with acne scars. And certainly if we subdivide those acne scars, specifically rolling acne scars, a lot of us have invested in these technologies and brought them to our practice for laxity as well. And I think that you can see some improvement for laxity. I think it's a little bit harder to actually get those results. Sometimes you need to be more aggressive with your overall settings. You need to do 3 passes at 3.5 millimeters or 3 millimeters, and then 2.5, and then 2. And then that really leads to some significant activation of the skin where you're actually seeing swelling and erythema and pinpoint bleeding. So Anna, what has your experience been in your patients for the RF microneedling devices and laxity?
So my device is called Scarlet, and we developed the protocol for skin tightening. So we named our protocol Bella FX. And basically, these are microneedles that go in and they arc between each other, not monopolar, it's bipolar, and create a little coagulation, effect around each pulse. And what that does is collagen contraction. So in the same way that we're inducing a healing response to repair acne scars, we also can tighten the skin. And we know that this electrocoagulation is the same thing we do in surgery. And we can see that when we're doing excision, the collagen is knitting together when we touch an area with the cautery. So RF is basically a type of cautery. And so when we're putting these needles down deeper into the skin, arcing between each other, we're contracting the dermis. So we have a really nice before and after result. Our patients are very happy with the collagen contraction that you see. And you can see these 2 before and afters. There is a little bit of a princess effect. So there's an immediate effect, and then there's an induction of a healing response so that the collagen is then remodeled over the following months. So we not only see skin tightening with RF microneedling, but we also see sort of a more robust, firm looking collagen. And when we treat the mid-face area, it actually has a side benefit of reducing tiny broken blood vessels, reducing pore size, because I don't know if you guys do electrocautery for sebaceous hyperplasia, but it's almost like doing that in a very low grade fashion all over the face. And when we do, we'll use this device, the Scarlett device, you can adjust the depth of the needles, and we do multiple passes. I usually do more passes in a certain vector to give an effective lift. And you can even treat behind the hairline to tighten the brows and the cheek area by tightening the skin behind the hairline. And so it's very popular at our office. You can do it as a single treatment or a series, and they can be spaced by a month to 6 weeks apart. I think it's interesting what Dr. Day said about the healing response, because I usually tell my patients that I like them to do their procedures within a few weeks of each other, because they're upregulating all these healing factors in their body. They're building collagen actively. And when you re-injure the skin, my impression was that you build collagen more effectively if you already have those raw materials ready. But it's interesting. I think I'm going to try delaying the third treatment by a few months and seeing if that gives them a nicer result.
So, and Mara, I know you've used several of these types of radio frequency devices, and there are certainly tips and tricks that everybody has to, number one, get patients through these treatments, and number two, to really identify who may be at risk for having post-inflammatory changes or patterning type changes on the skin. So for instance, in our practice, we incorporate Pronox routinely for patients who are getting bipolar fractional radio frequency treatments, because there is a little bit of discomfort. And prior to Pronox, we actually did the mesoram needles, where we actually used tumescent anesthesia throughout the entire face to numb it up. And there are still patients who had done that several years ago that still like to continue to do that. So what are the techniques that you use to really get your patients through this type of treatment?
Yeah, certainly. So I think that, we don't have Pronox here at the university. And so we've resorted to the 23% lidocaine, 7% tetracaine mixture. And we extend the time. So these patients will wait 90 minutes if they have to with a topical numbing agent on their skin. And then we also use the Zimmer in combination with the treatment. So the two, some people will say they don't like the cold air, and so we'll stop it. But most often it really helps with pain control. The other thing I wanted to mention is just to pay attention to those treatments around the neck. I think that patterning that you mentioned is a real thing. It's that like grid-like pattern that is left over post RF microneedling treatments. In those sort of mid-range skin types, 3, 4, 4, 5, that patterning can last a really long time. And I think part of it has to do with not putting enough sort of counter tension on those areas when you're treating, especially if there was a significant amount of laxity. There's been an uptick in patients wanting the tech neck lines being treated in addition to laxity, even in the 40, 50 age range. And that patterning I've seen persist, and people don't like it. So I think that has to do with, the impedance of your individual device. In addition to, the technique, because a lot of these procedures are being delegated. And so you're not always watching what's happening in those areas.
We have not had a single case of patterning with our device, but I don't know if that has to do with technique or post-procedure. We immediately apply a clobetasol foam to reduce the inflammation immediately, and obviously SPF. But I'm not sure why. It definitely does have a red pattern, a square pattern where the pulses come down, but we haven't had a hyperpigmentation issue. And that's why I always say this procedure is colorblind. And that's what I love about it, because I treat all different types of skin, all different skin types with it, and haven't had an issue.
So, I think this procedure is colorblind as well, but I would also add that dermatographism is colorblind as well. And at least in our experience, there's no rhyme or reason why somebody may actually develop patterning, but we seem to see it more in people who have a tendency to be dermatographic. So for people who aren't familiar with that concept, there are some people where you simply just scratch them and they develop sort of erythema and swelling in that particular area. And for dermatologists, this is something that we actually see very, very commonly. So what Dr. Guanche is describing in using topical steroids can be very helpful. One trick that we've actually noticed where we used to go right to topical steroids, but for some of these patients, they may actually be fair complected, they may have rosacea. I'm a little hesitant to use high potency topical steroids on their face because of the rosacea, or I don't want to stir up some perioral dermatitis. So I've actually gone to using a non-ablative fractional pretty routinely on anybody who complains of patterning. So there's 1927 wavelength lasers, there's various types of forms of that. You can have the Cyton Moxie, you can have the Lace Ultra from Neutronic, or you can have Fraxel Dual or Clear and Brilliant, but they all really rolling over the skin can actually help improve the appearance of that patterning right away. And in some cases, when those patients do develop patterning, we just integrate that type of non-ablative fractional right on top of their treatment, on their successive treatments to hopefully try to avoid that. And that's been pretty successful. One of the most common uses of microneedling in our office is really what I call maintenance microneedling, where somebody has done laser resurfacing with me, whether it's full field erbium or fractional erbium, fractional CO2, or RF microneedling type devices. And they've gotten to a point where they're happy with the improvement. And there's a lot of discussion about sort of collagen induction and low level of collagen inductions. So for many of these people, I'll actually have them put on a program where they're doing microneedling every quarter just to sort of keep things going. And I talked a little bit about that in a Vogue.com article. And I know you guys do a lot of the national magazines and a lot of the media. And I think that that's something that we see a lot of in these magazines is really that maintenance sort of therapy approach. So are you guys doing that in your practice as well?
Absolutely. Almost every procedure we do, whether it be V-beam or microneedling or Fraxel, everything requires maintenance, right? I tell people you have to wash your car again, don't you? So yeah, they come in for collagen stimulation maintenance. So every 4 to 6 months you do it for maintenance, similar to Botox injections. So it's a very simple, easy technique with no downtime, easy to pop in and just get a skin perfecting technique. And you're right, I neglected to say that it does also do a low grade collagen stimulation because, I mean, you are microneedling the skin, even though it's extremely shallow.
What we do in my office is we make a maintenance calendar for every patient where they come in and we say, this is what I think you'll need for the year. And that can include maintenance microneedling, Clear and Brilliant, Fotona, 4D or 5D, but they have a list of what they do and they actually look forward to it. They bring in the list and they say, okay, this is what we're up to now. So it's something that really works in my practice.
Well, I appreciate all of you joining us for another episode of Scientifically Speaking in conjunction with Modern Aesthetic Magazine and for Practical Dermatology Magazine. And I encourage you all to check out other episodes. We've actually talked about radio frequency in the past. We've talked about fillers. We've talked about some of the pearls and pitfalls in trying to use energy-based devices in darker skin types. So there's a lot of great segments and we appreciate you joining us.